You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for January 22nd, 2021. This week, COVID myocarditis, the Polypill, low-value care, and tricuspid valve clipping. First, COVID. My review of the Johns Hopkins site today reveals mostly good news. Cases in the U.S., especially in California, are on a steep decline. I did notice some problem spots. What's going on in Spain and Portugal and Monaco? To my friends there, I hope things turn around soon. Another piece of good news is vaccines are being rolled out, albeit with difficulty here in the U.S. Now, speaking of our rocky vaccine rollouts, one thing I hope gets noticed in the historical accounts of the pandemic is how the absence of a truly national or even state-level health system is problematic in public health emergencies. Our patchwork of private hospitals that compete against each other in communities is really, really good for transferring wealth to the healthcare industry, but it's not so good at delivering health to the community. I don't know if our current government will improve the unjust U.S. healthcare system, but it's hard to believe it could get much worse. Now let's talk about COVID myocarditis. Let's first recall that long before this pandemic, viruses were well-known causes of pericarditis and myocarditis. But despite that prior knowledge, in mid-2020, two small studies suggested COVID-19 had special proclivity to cause cardiac inflammation. These studies and their outsized media coverage induced widespread fear. But two studies published recently suggest SARS-CoV-2 may be more like other respiratory viruses, namely it can cause myocardial inflammation, but infrequently. About a month ago, Circulation published a research letter from Vanderbilt researchers in which they did cardiac MR, CMR, in 59 athletes who had had COVID, 60 athletic controls, and 27 healthy controls. The median time from the positive PCR was 21 days. 78% of the positive athletes had mild symptoms, and 22% had no symptoms. Only two of the 59 positive athletes met criteria for myocarditis. One athlete had pericarditis. Now, the athletes with positive scans had normal ECGs, echoes, troponins, but one of the positive athletes did develop an EF of 45% by echo down the road, and this was done for dyspnea on exertion. Most standard CMR parameters were similar between COVID positive athletes and athletic controls. For instance, focal LGE, late gadolinium enhancement, isolated to the inferoseptal RV insertion, was present in 22% of COVID athletes and 24% of athletic controls. The authors made two conclusions. One is easy to agree with, the other not so much. They concluded that the incidence of myocarditis after COVID-19 is modest at 3%, and I agree with that. But they also concluded that COVID myocarditis may be missed without CMR. I don't know about this because the only significant finding, the one athlete with mild decrease in EF, was done for symptoms. Thus, from this paper, I don't think they can claim that standard clinical screening would have missed anything important. Now, a final note, especially for the sports cardiology audience, their findings confirm that focal inferoseptal RV insertion LGE is common in athletes that may represent remodeling from athletic training, and this should not be conflated with myocarditis. I like this paper, though, because it highlights the need for having proper controls when studying viral myocarditis in athletes, especially when we're using CMR. JAMA Cardiology published the second post-COVID CMR study done in athletes. The University of Wisconsin authors report on 145 student athletes there who had COVID and CMR. 49% had mild symptoms, 28% had moderate symptoms, and 17% had no symptoms. No patient needed to be in the hospital, and the median time to MR after positive test 15 days. This group found 2 patients, or 1.4%, had MR findings consistent with myocarditis. 1 patient had marked non-ischemic late gadolinium enhancement and T2 weighted signal abnormalities over multiple segments, along with an abnormal serum troponin level. This patient also had nonspecific ST&T changes on the ECG, but a normal LVEF by echo. At 1 month MRI reevaluation, the LGE findings were unchanged, but T2 weighted signal abnormalities had improved, as did the troponin. The second patient they discovered had myocarditis, had 1 centimeter non-ischemic mild LGE and mild T2 weighted signal abnormalities, but this patient had normal lab values. At 1 month MRI follow-up here, the T2 weighted signal abnormalities and LGE had resolved. This patient had symptoms from COVID, but none at the time of the MRI. Now, given the low prevalence of findings, the authors here in this study concluded that the utility of cardiac MRI as a screening tool for myocarditis in this patient population is questionable. Now, I cannot tell you the page views of the first paper, but the University of Wisconsin paper has been viewed about 25,000 times. That is 825,000 fewer page views than the first German paper, the one that nearly canceled sports. I still think we need more studies on this virus, but the seriously limited nature of the 2 earlier CMR studies, coupled with these more recent and larger series, suggest 1, there is absolutely no way we should be doing routine CMR in asymptomatic young people after COVID. And 2, it is highly likely, given the prior knowledge of myocarditis from numerous pathogens, that SARS-CoV-2 has no more or no less proclivity to inflame heart cells than the slew of other viruses that can induce cardiac inflammation. All right, next topic is the Polypill. Now, it's hard to remember that it's during the pandemic, but heart disease remains a major threat to human life, and risk factors like hypertension and elevated cholesterol increase the risk of major adverse cardiac events. Of course, risk factors are modifiable with drugs and lifestyle. But drugs only work if people take them. So the notion of the Polypill is to put numerous chemicals into one capsule, thereby improving adherence. And on a population level, if you reduce the incidence of MACE, even by a little, you could improve the health of a population. The problem, of course, is that people are not populations. People are individuals. In the TIPS-3 trial, published this week in New England Journal of Medicine, the McMaster's team, led by Professor Salem Youssef, studied the use of the Polypill to reduce MACE, major adverse cardiac events. The 5-year trial of about 5,700 patients was conducted in 86 centers in 9 countries. Patients were about 64 years old. They had intermediate to high CV risk. For instance, the mean LDL of patients was about 120 and the mean blood pressure 144/84. Now, the main comparison of this study was the Polypill versus placebo. And what was in the Polypill? 40 milligrams of simvastatin, 100 milligrams of atenolol, 25 milligrams of HCTZ, and 10 milligrams of ramipril. The trial also had an aspirin versus placebo arm and a Polypill plus aspirin versus double placebo arm, but let's focus on the main analysis. First, there was a 4-week run-in period in which 1 in 4 patients were excluded. Let me repeat that. 1 in 4 patients were excluded. So right off the bat, you are selecting people who can take the pill that has 4 drugs in it. The primary endpoint was a composite of 6 things: CV death, MI, stroke, cardiac arrest, heart failure, or revascularization. In the New England paper, there was the telltale sign of small effect sizes, and that is the Kaplan-Meier curves had an insert with the curves displayed on a truncated y-axis. That is because the Kaplan-Meier curves without truncated axis were basically overlapping. Now, here were the numbers. Out of about 5,700 patients randomized, 126 or 4.4% had a primary outcome event in the Polypill arm versus 157 patients or 5.5% had a primary event in the placebo arm. The hazard ratio was 0.79 and the confidence intervals went from 0.63 to 1.00. So technically, the 21% relative risk reduction or 1.1% absolute risk reduction did not reach statistical significance. The trial was powered to find a 35% relative risk reduction. The only component of the primary endpoint that significantly differed was revascularization. Hard endpoints like MI, stroke, CV death, heart failure, and out-of-hospital cardiac arrest were all non-significantly different. Now, the aspirin alone versus placebo comparison mirrored the three null trials in 2018, ARRIVE, ASCEND, and ESPRIT, and this did not show a significant reduction in MACE, and I think we need to be stopping aspirin when it's used for primary prevention, period. Now, I have to announce that I now have a Bayesian calculator on my desktop. I downloaded it from Sanjay Kaul and George Diamond paper. Now remember, p-values give you the probability of the data given the hypothesis of no effect. Bayesian analysis give you the probability of an effect given the data. So the trial was powered to find a 35% reduction in MACE. Okay then, given these results, what are the chances there was a better than 35% reduction? Using the Bayesian calculator, it was only 5%. That means that there was a 95% chance that the effect was less than 35%. Now, the chance that this data is consistent with a 25% reduction in MACE is still only 31%. So adverse effect-wise, 3 times more patients in the Polypill arm stopped the drug for dizziness or hypotension, and this was despite a 4-week run-in period that selected out patients that couldn't take the drug. My comments are, the bottom line is that a pill with solid doses of 3 blood pressure drugs and a statin had very modest effects in individuals with intermediate to high risk. And this was in a carefully done trial with a run-in period. These were 64-year-old patients with both hypertension and high cholesterol. Now, the authors explain in the discussion that LDL lowering and blood pressure reduction was less than expected, and this may explain the smaller effect size. And I don't know about that explanation, but the event rates were low, only about 4 to 5% over 5 years. And of course, low event rates are always hard to lower much more. Also, it's peculiar that the authors felt it was okay to randomize patients with intermediate to high risk and high LDLs to a non-statin placebo arm. I mean, the same authors have already published the HOPE trial, which showed a robust 24% reduction in MACE with rosuvastatin 10 milligrams. So, had the Polypill been compared to a statin alone, I don't think there's any way we would have had an effect. The Polypill may work in resource-poor countries, but a capsule that has a 95% chance of having less than a 35% reduction in a composite endpoint, mostly consisting of non-fatal events, is not compelling. I'm happy to hear from you if you think I'm wrong. Let me know in the comments on the website or on Twitter. Next topic, low-value care. The Annals of Internal Medicine has published a research letter from a number of authors that attempt to estimate the share of low-value spending on older adults that is directly related to the PCP, primary care physician or provider. The notion is that low-value care is a big problem in our system, and some have felt that increasing the role of primary care physicians will help reduce low-value care. Now, I highlight this paper because I am simple-minded about healthcare policy. My idea is that if we simply reduce the fraction of wasteful things we do, there'd be more dollars to reduce the inequities. I am reminded of this every time I walk by our nuclear medicine department and see a frail older person who is in diapers getting a perfusion scan, or when my asymptomatic 80-year-old patient with permanent AFib wants a cath because he just had a coronary artery calcium score done and it was high. Now, the way in which the authors tried to answer the question is by taking a 20% random sample of a huge Medicare claims database. They then calculated the percentage of all low-value care spending resulting from the PCP or some other doctor. The bottom line, was that 15% of low-value services were PCP performed or ordered, 26% of low-value services were PCP referred, but 60% of low-value services were performed by non-PCPs. And which non-PCP specialty had the most low-value care? Yes, you guessed it, cardiology. We accounted for 27% of the low-value spending. So the author's conclusion was that the PCPs generate only a small part of the $75 billion to $100 billion wasted every year on low-value care. This paper definitely appeals to my prior biases, but it had serious limitations. It excluded hospital outpatient services because those claims don't identify the referring physician. Consider also that low-value services, including PCI and stable coronary disease or Swan-Ganz catheter use in the ICU, it's not like PCPs have a big role in the inpatient setting. So I conclude that both PCPs and specialists participate in tons of low-value care. And most U.S. communities have a perfect storm for low-value care, right? First, patients expect it. People feel cared for if they are tested, no matter the non-benefit. Think carotid artery screening in asymptomatic people. Second, we have evolved into a specialty-run medical community. At least many medical communities in the U.S. have. Generalists are frightened to manage things conservatively. Thus, there's a low bar for referral for testing and consultation. And third, not all, but for many U.S. clinicians, productivity is rewarded financially. So fixing low-value care will be like fixing a complex condition like AF. It'll have to come with fixing the root problems. I see these as education of patients, education of clinicians, and changing the incentive structure of reimbursement and compensation. Last topic is tricuspid valve clipping. Now, I intentionally positioned this topic after the low-value care discussion. My friends, one of the goals of this podcast is to help you not be bamboozled. One heuristic or shortcut is to listen for words that ought to put you on guard. One of these words is, quote, single arm to describe a study. Another combination of words is, quote, unmet need. When you hear these, be on the alert. Now let's talk about the recently published one-year results of the Triluminate study. In June of 2020, Lancet published the 6 months results of this 85-patient single-arm study of edge-to-edge repair using what Abbott calls the TriClip to reduce tricuspid regurgitation. The main findings of that analysis were that 86% of patients had a reduction in TR by echo, and at 6 months, 5 patients experienced a major adverse event, which was less than the author's pre-specified performance goal of 39%, although I don't know where that comes from. I wrote a column in June expressing serious reservations about normalizing this procedure based on what amounts to what my friend Luis Correa calls an unstudy. I mean, Triluminate is a nice name, but the study is without a comparator. And since you can see the clip, it's utterly impossible to blind echo readers. This month, the Journal American College of Cardiology published the one-year results, and TR was reduced in 71% of patients. The authors also reported improvements in New York Heart Association functional class, 6-minute walk, and KCCQ, as well as significant reverse RV modeling in size and function. The overall major adverse event rate in all-cause mortality was both 7% at 1 year. The authors then concluded that transcatheter tricuspid valve repair using the TriClip device was found to be safe and effective in patients with moderate or greater TR. So my comments are that it is fine to report the results of a novel procedure, but it is totally not fine to make such overreaching conclusions. First of all, there was missing data on 22 patients. Pause on that for a moment. JACC editors and peer reviewers let the authors claim safety and efficacy with missing data in 1 of 4 patients. How do you claim anything with this much missing data? And safety is always a relative term. Safe compared with what? To claim anything useful about safety, you need to have a real control arm. Single-arm studies don't have that. And the clinical endpoints here are all subjective. This is important because without blinding, there is surely a placebo effect. The 6-minute walk test increased by a mere 30 meters. As I wrote in June of 2020, and I'll link to, edge-to-edge repair of the tricuspid valve might be useful in highly selected patients. but the medical conservative believes the onus is on the proponents of such a procedure to show its benefit in proper randomized trials. Journalist Patrice Wendling has very nice coverage of the paper, including references to larger trials which are ongoing or soon to start. Now, if these patients are as sick and frail as the authors say, then it should be easy to show benefit in real clinical outcomes like heart failure hospitalizations or CV death or overall death. Until then, we cannot know whether or not this procedure is safe or effective. And I really wish editors and reviewers were a little harder on authors in regard to their conclusions. So that's it for this week in cardiology. As always, I'm grateful that you listened, and please, friends, remember, it really helps if you can give us a rating or write a review. This way others can find us. Till next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.